This video exists because of a comment. Martha wrote to me after my video on lung health. She asked about bronchiectasis, and she mentioned that her father was a heavy smoker. Martha, thank you. I am going to answer you properly with the actual numbers because this is one of the most underdiagnosed conditions in respiratory medicine. And I want to start with a figure that I think will surprise you. In 2024, researchers published a survey of bronchiectasis patients across Europe, conducted jointly by a research network called EMBARC and the European Lung Foundation. Over 700 patients responded. 1 in 4 of them, 25.4%, had symptoms for 10 years or longer before anyone diagnosed them. Another 15% had symptoms for 5 to 10 years. And more than a quarter, 25.7%, had been given the wrong diagnosis entirely. 96 were told they had asthma, 27 were told chronic bronchitis, 18 were told COPD. An Italian study published the same year found the median time from symptom onset to a chest CT scan was roughly 2.5 years, and the median time to diagnosis about 3.5 years. The authors called that unacceptable and noted that Spanish and English cohorts had reported delays of 12 and 17 years. So this is a condition where people cough up phlegm for a decade while being treated for something else. Today I am going to explain what it actually is, the one scan that diagnoses it, which is not a chest X-ray. The treatment that international guidelines call a strong recommendation, which most patients are never taught. A common pharmacy medicine that people with this condition should generally avoid. And Martha, your specific question about smoking, where the honest answer is more interesting than a simple yes. Let me start with how common it is, because the numbers explain why this matters to my audience specifically. Researchers analyzing American healthcare claims data found the overall prevalence among U.S. adults was about 139 cases per 100,000, but it is not evenly distributed. Among adults aged 18 to 34, it was 7 per 100,000. Among adults 75 and older, it was 812 per 100,000. That is more than a 100-fold difference. A separate analysis of Medicare data covering over 250,000 patients found an average annual prevalence of 701 per 100,000. The mean age at new diagnosis was 76. 65% were women. And here is the figure that matters most for Martha's question. 51% of them also carried a diagnosis of COPD. Overall, the estimates suggest somewhere between 340,000 and 522,000 American adults were being treated for this in a single year, and prevalence has been rising by roughly 8% annually since 2001, which researchers attribute substantially to increased use of CT scanning, finding cases that were always there. Now let me explain what bronchiectasis actually is. Picture the airways in your lungs as a tree. The windpipe is the trunk, dividing into branches, dividing again, narrowing each time. In healthy lungs, those branches taper smoothly. In bronchiectasis, sections become permanently widened and scarred, and they stop tapering. Radiologists have precise criteria for this. They compare the internal diameter of the airway to the artery running alongside it. Normally, the artery is the larger of the two. When the ratio reaches 1.5 or above, that is abnormal. They also look for airways that fail to taper, described as tram tracks, and airways visible within 1 centimeter of the chest wall, where they should be too small to see. Now, why does widening cause disease? Your airways are lined with millions of microscopic hairs called cilia, sitting in a thin mucus layer. They beat in coordinated waves continuously, moving mucus upward and out like a conveyor belt. Every particle of dust and every inhaled bacterium is caught and escorted out, and you swallow the result without noticing. That system is why your lungs are not permanently infected. When an airway is widened and scarred, that conveyor belt fails in that section. Mucus pools. Pooled, warm, nutrient-rich mucus is an excellent home for bacteria. Your immune system attacks them, and that inflammation damages the airway wall further, which causes more widening, which worsens clearance. Doctors used to call this the vicious cycle. The current European guidelines describe it as a vicious vortex with four interacting components: airway inflammation, impaired mucociliary clearance, airway infection, and structural lung damage. That framing is not academic. It tells you that you do not need to fix all four. You interrupt the loop wherever you can reach it. Now, Martha, your question about your father. Smoking is not the classic cause of bronchiectasis, and I want to be precise about that. Data from the United States Bronchiectasis Research Registry, published in 2017 and covering 1,826 patients, found that 68% had a history of pneumonia, 29% had asthma, 20% had COPD. Note the order. Prior lung infection dominates. Many people with primary bronchiectasis have never smoked, and it is notably more common in women who never smoked, which is why the female to male ratio runs roughly 1.5 to 2 to 1. The recognized causes include severe past infection, sometimes from childhood pneumonia, whooping cough, measles, or tuberculosis decades earlier. Immune deficiencies, which are diagnosable and treatable. Rheumatoid arthritis and other autoimmune conditions. Inherited disorders of the cilia themselves. An allergic reaction to a fungus called aspergillus. Repeated aspiration of food or stomach acid, and in a substantial share of cases, no cause is ever found. But here is where smoking enters, and this is the part relevant to your father. Smoking causes COPD. And COPD and bronchiectasis overlap far more than most people realize. Studies suggest up to half of patients with severe COPD have bronchiectasis visible on CT. That Medicare analysis I mentioned found 51% of bronchiectasis patients carried a COPD diagnosis, and those with both were more than twice as likely to have been hospitalized for respiratory infection in the baseline period, 16% versus 7%. They were also far more likely to have a smoking history, 46% versus 17%. Doctors now call this bronchiectasis, COPD overlap syndrome. A meta-analysis of over 5,000 COPD patients found that those with coexisting bronchiectasis had roughly double the exacerbation risk, 4 times the rate of bacterial colonization, and double the mortality compared with COPD alone. And here is the treatment consequence, which is the practical part. Inhaled corticosteroids are standard in COPD. They are not recommended for most patients with bronchiectasis, yet data from the European registry indicate more than half of bronchiectasis patients are receiving them. So this distinction changes prescribing. Martha, if your father has a long-standing productive cough and has been treated as straightforward COPD, the single question worth asking is whether he has ever had a CT scan of his chest, which brings me to diagnosis. Bronchiectasis is diagnosed by a high-resolution CT scan, sometimes called thin section CT. A standard chest X-ray frequently misses it. People are told their X-ray is clear, conclude their lungs are fine, and the condition continues quietly for years. The CT is highly accurate, with reported false positive and false negative rates of about 1% and 2% respectively. So who should ask? British Thoracic Society guidance suggests considering the diagnosis in anyone with a recurrent or persistent productive cough lasting more than 8 weeks. 8 weeks. If someone brings up phlegm most days, most months, year after year, and everyone has accepted that as their normal, that is the description that should trigger a scan. Clinicians point to one feature that helps distinguish it. In COPD, daily cough is common, but discolored phlegm typically appears only during flare-ups. In bronchiectasis, chronically colored sputum between flare-ups is characteristic. Other clues include repeated infections settling in the same part of the lung and coughing small amounts of blood, which is more common in bronchiectasis than in COPD or asthma. Ask by name. Ask whether a high-resolution CT of the chest is appropriate. If this is useful, tell me in the comments whether you or someone in your family has a cough that never really goes away. I read everyone, and Martha's question is exactly why. Now, the treatment, and this is where the guidelines are unusually direct. The European Respiratory Society published an updated bronchiectasis guideline on the 18th of December, 2025, developed using the grade framework across 8 structured clinical questions. Airway clearance received a strong recommendation, which is the highest category those guidelines use. Commentators on the update summarized its emphasis as doing the simple things well. The logic follows directly from the vortex. If pooled mucus drives the cycle, physically removing it daily interrupts the cycle. And there is outcome data, not just theory. A Taiwanese study of patients hospitalized with severe bronchiectasis exacerbations examined 1-year mortality. After multivariate adjustment, airway clearance therapy was associated with a hazard ratio of 0.50, roughly half the risk of dying within a year. Now, I am not going to teach you a technique from a video, and I want to explain why rather than simply withholding. These techniques are adapted to which lobes are affected and to what your body tolerates. Some positions provoke breathlessness or reflux if applied wrongly. What I will give you is the sentence to say. Ask your doctor for a referral to a respiratory physiotherapist for airway clearance training. The techniques have names you may hear. The active cycle of breathing technique, autogenic drainage, positive expiratory pressure devices, some of which oscillate, and nebulize saline beforehand in some patients to loosen secretions. Most people do this once or twice daily, taking 15 to 30 minutes. Now, the warning I promised, which surprises almost everyone, cough suppressants. In bronchiectasis, coughing is not the disease. Coughing is the backup system for a mucociliary escalator that has failed. Suppressing it leaves the mucus in place, where it feeds the vortex. So over-the-counter medicines designed to stop a cough are generally inappropriate here, which is quite different from advice for an ordinary viral cough. If someone is quieting a productive cough every night with a bottle from the pharmacy that deserves a conversation with their doctor, please do check with your own doctor rather than acting on this alone. But the principle stands. Here, the cough is doing a job. Now, one more thing worth knowing, because it changes management substantially. Sputum culture. Guidelines recommend knowing which organisms live in a patient's airways, and one in particular matters, Pseudomonas aeruginosa. A meta-analysis pooling 21 cohort studies with 3,683 patients found Pseudomonas colonization associated with an odds ratio for mortality of 2.95, roughly a threefold increase, along with substantially higher hospital admissions and exacerbations. Now, I want to give you the honest complication because the picture is more nuanced than that headline. A later prospective study of over 1,200 patients found that on univariate analysis, Pseudomonas carried a hazard ratio for death of 2.02, but after adjusting for age, low body weight, and exacerbation frequency, it was no longer an independent predictor. The interpretation most researchers favor is that Pseudomonas is both a driver of poor outcomes and a marker of already severe disease. Either way, knowing it is present changes antibiotic choice. And there is treatment evidence. A meta-analysis of 20 studies covering 3,468 patients found inhaled antibiotics reduced exacerbation frequency with a rate ratio of 0.78 and severe exacerbations with a rate ratio of 0.48. That is roughly having severe exacerbations in appropriate patients. If someone is having repeated flare-ups, ask whether a sputum culture has been sent, and ask specifically whether testing for non-tuberculous mycobacteria is appropriate, because that is a distinct infection requiring entirely different treatment and it is easily missed. Briefly, the other things that help. Vaccination matters more here than almost anywhere, because each respiratory infection can cause a step down in function never fully regained. Pulmonary rehabilitation has real evidence and is one of the most underused effective treatments in respiratory medicine. Hydration helps mucus move, subject to your doctor's guidance if you have heart or kidney disease. Nutrition and protein matter since low body weight was an independent predictor of mortality in that prospective cohort. And reflux deserves mention because silent aspiration can drive airway damage and is treatable. Now, the things needing prompt attention. Coughing up blood always warrants assessment. Streaks are common in this condition and still merit a call. A large volume of fresh blood, more than a few teaspoons, is an emergency requiring an ambulance because the widened airways sit close to enlarged bronchial arteries. A flare-up, meaning several days of worsening cough, increased sputum volume, changed sputum color, more breathlessness, or feeling unwell, should be treated promptly rather than waited out. Many patients benefit from an action plan agreed in advance, and new fever, confusion, or drowsiness in an older adult with lung disease needs same-day attention. 3 honest statements before I close. Bronchiectasis is permanent structural damage, and I am not going to tell you it can be reversed. What can change substantially is infection frequency, symptom burden, and rate of progression. And this video is education, not medical advice. I am a physician, but I am not your physician. And this condition genuinely warrants specialist respiratory input. Martha, let me answer you as directly as I can. Your father's smoking probably did not cause bronchiectasis by itself, but if it caused COPD, then bronchiectasis may well be sitting alongside it. And in that Medicare cohort, more than half of bronchiectasis patients had exactly that combination. It doubles exacerbation risk, doubles mortality risk, and is treated differently. So 4 questions, all askable at one appointment. Has he ever had a high-resolution CT of his chest rather than only an X-ray? Has anyone ever referred him to a respiratory physiotherapist for airway clearance? Has a sputum sample ever been cultured to see what is growing, and is he suppressing a productive cough with something from the pharmacy? Given that a quarter of patients in that European survey waited 10 years or more for a diagnosis, those questions are worth asking even if the answer turns out to be no. Thank you for the question, Martha. It made a better video than anything I had planned this week. And to everyone else, if there is a condition you would like explained properly, put it in the comments. I read them, and as Martha has just shown, sometimes they become the video. Take care of yourselves.